So we're not going into a movie session now, but being that I'm talking about a topic that we have not talked about today, I want to set the ground of what I will mean by psychosis in this presentation. What you see up on the screen is a movie that came out last year about psychosis. And what they try to depict is the loss of touch with reality that patients that have psychosis have. So in this picture, you see a lady who is seeing hands crawling towards her, many pairs of hands that actually have no bodies attached to them. So in this study, I looked at people who have delusions and hallucinations as individuals that have psychosis. I'll not go into the other definitions of psychosis that may be present. This is just to emphasize the burden of HIV infection that is highest in sub-Saharan Africa, and consequently we have more individuals that get complications that result from HIV infection, and these include psychiatric complications. So even though the mental and neurological disorders have an intertwined relationship among HIV individuals, when it comes to interventions, like I mentioned in the morning about who do you give antiretroviral therapy, it's not really considered in our setting, or even if it were to be considered, it may be sometimes be overlooked due to the scarcity of resources. Now, some of the problems that may arise come from the fact that we still have a high prevalence of HIV infection, even though this has gone down from 20% in the mid-1990s to a current 5% in men and 7.5% in women. We have about 1 million people who are living with HIV infection, and as of the end of last year, there were about 120,000 new infections, which was a cause for worry because we thought we were decreasing with the prevalence, but we seem to see a slight increase in new infections, and this is for a number of reasons that I will not go into for now. This caption comes from a daily in my country that where we still have questions as to when should one start antiretroviral therapy, whereas it's well known elsewhere as to when one should begin on antiretroviral therapy. We still have questions on who should start on treatment and when should they start on treatment. In the right-hand corner of this caption, you see someone campaigning for presidency, and was promising change to come with his being voted into power. Well, he didn't get the vote, so I'm hoping that change will come, but maybe not through him, but through other means, as far as treating patients with antiretroviral, rather patients with HIV/AIDS is concerned. So it's been established through all the studies that have been presented today that antiretroviral therapy can improve neurocognitive function, but so can it improve outcomes for mental health. We do have a high burden of individuals with mental health problems with a limited access to antiretroviral therapy. As of the end of last year, we only had 40 people who were actually receiving antiretroviral therapy, so 60% of those that actually need it were not getting it. So why did we decide to concentrate on looking at cognitive impairment in individuals that have psychosis? A number of studies have shown that cognitive impairment is present in individuals that may not have psychosis, and that depression, illness is also common. Psychosis has also been found in a few, to range between 1.4 to 15% of patients that have HIV. So the rationale of this study was to see the effect of cognitive impairment, or to see the effect of psychosis in individuals who are HIV infected, and how they would perform on neuropsychological testing. And we compared HIV positive and HIV negative individuals. All patients had to have psychosis from the beginning. So the setting was Uganda. As you see on the map, the patients were collected. Kampala is at the center here. We collected the patients from 2 national referral hospitals. One is the General National Referral Hospital, and the other was the Psychiatric Referral Hospital. We subjected the individuals to a variety of neuropsychological tests, as we have elaborated in the morning. And we got 478 individuals who had been admitted with psychosis. 156 of these were HIV positive and 322 were HIV negative, and we followed them for 6 months. So in the analysis, we mainly used chi-square test and logistic regression. We found that the mean age for the HIV positives was 33 years versus 29 years for the HIV negatives. And this is typical of what we normally see when we do studies in HIV positive individuals, when we do studies in patients that have psychosis, we tend to see that the ones who will be HIV positive tend to be a little older. There were more females, contributing to 71% of the whole study sample, and this was statistically significant. Looking at the type of presentation of these different types of psychosis, we found that the HIV positives tended to have more irritability. They tended to be more impaired in their content of thought. They had more guilt feelings and were more disoriented. So this graph shows the difference between the HIV positives and negatives as far as the different diagnoses were mainly looking at, which were mania, psychotic disorder not otherwise specified, major depression, and schizophrenia. What I want you to pick is that whereas all the other disorders were more common in the HIV negative individuals, the psychotic disorder not otherwise specified was more prevalent in the HIV positive individuals, pointing to a lack of clarity in the kind of symptomatology that HIV positive individuals, more so those who may be presenting with psychosis as a first time episode in their lives, that this may sometimes be different from the primary psychiatric disorders that we may be more used to. So we assessed cognitive functioning, and for purposes of the study, I classified mild cognitive dysfunction as one having one standard deviation below the mean on 2 or more tests, and I considered it as severe if they had 2 standard deviations below the mean on 2 or more tests. And what we found that the HIV positives, what we found that is the HIV positives tended to have a severer form of cognitive impairment, and this was statistically significant. We also looked at the cognitive impairment at baseline for the different types of psychosis, and as we were discussing in the morning, that there is usually patients that have psychosis may also have other reasons as to why they may not perform very well on neuropsychological tests, and this clearly comes out on this slide, where you see that a number of people seem to be cognitively impaired, irrespective of whatever psychiatric diagnosis that they may have had. So I mentioned that we followed up these individuals over a period of 6 months, and what I want you to pick in this is that many people converted to having a normal level of psychological functioning. The HIV negatives improved and continued to improve over the 6 months. The HIV positives did improve initially at the 6 months, but that improvement was not as sustained as that of the HIV positive individuals. So we did conclude that cognitive impairment in psychosis was worsened by HIV infection, and therefore we would need to have strategies for improving the management of neuropsychological complications of HIV-infected individuals, one of which is stressing the point of starting of people on antiretroviral treatment, even when their CD4s may not have dropped as low as is required by WHO guidelines. I need to acknowledge people who are my supervisors, the people who funded this study, which was the Swedish International Development Agency, study participants and the study teams. And these are two pictures of the two referral hospitals, Mulago Hospital and Butabika Hospital in Uganda. I thank you for your attention.